Every 40 seconds, a brain shuts down somewhere in this nation. Not from aging, not from misfortune, from a sequence of events that began days, sometimes weeks, before the actual stroke occurred. And here's the detail nobody communicates clearly enough. In the majority of cases, that sequence produces signals first, real specific physical signals. The brain does not simply collapse without notice. It alerts. Most people just never discovered what that alert sounds like. That is precisely what this video is going to address. In working with adults over 60, the pattern that keeps emerging is this. People who suffer a major stroke almost always experienced at least one warning episode in the days before it struck. They sensed something. They observed something. And then it passed, so they dismissed it. That moment, dismissing it was the most dangerous choice a person can make. And it almost always traces back to one thing. They did not recognize what they were experiencing. What those brief episodes are termed in medicine is a transient ischemic attack, TIA for short. Transient simply means temporary. It arrives and it departs. But here is what research demonstrates with uncomfortable clarity. ATIA is not a close call that resolved itself. It is your brain providing you a timed window to prevent the real stroke. That window is roughly 72 hours. After a TIA, the risk of a full stroke in the following 3 days is genuinely high. Not theoretical, not something that strikes other people. Here are the 5 warning signs. And I want to begin with number 5 because it is the one almost nobody discusses, and it involves a connection between your eye and your brain that most people have never been informed about. Once you grasp it, you will never view a vision disturbance the same way again. Warning sign number 5, temporary blindness or a gray curtain descending over one eye. This one strikes fast. You are heading toward the kitchen or you glance up from the newspaper and one eye goes dark like someone drew a shade down over it or coated the lens with gray haze. It lasts maybe 30 seconds, maybe a minute. Then it clears and you think, well, that was odd, and you continue on. What actually occurred? A tiny fragment of plaque or a small clot detached from the wall of your carotid artery, the main artery in your neck, traveled upward and briefly blocked the small artery that supplies your eye. Your retina lost its blood supply for a moment. Vision went dark, then the clot shifted, flow resumed, and sight returned. Here's what makes that moment so critical. The artery that supplies your eye is a direct branch of the internal carotid artery, the same artery supplying your brain. That clot could have traveled 2 millimeters in a different direction. Instead of a 1-minute blackout in your eye, you were facing loss of speech, paralysis on one side, or worse. Neurologists have a Latin term for this episode, amaurosis fugax, fleeting blindness. When a patient describes it, the response is not, let us observe it. It is, get to imaging today. Hospital records reveal a pattern where a person has 2 or 3 of these eye episodes, dismisses each one, and the next event is the full stroke. Now, here is something about the retina that most people have never learned, and it explains why this warning sign is so precise. The retina has one of the highest metabolic demands of any tissue in the human body. It consumes oxygen and glucose faster than almost anything else, which is why it is so responsive to even the briefest interruption in blood flow. A muscle in your leg can withstand reduced circulation for several minutes before damage begins. The retina starts signaling distress in under 10 seconds. That darkness you notice is not just a visual glitch. It is one of the most sensitive early warning instruments your body possesses, and it just activated. There is one more connection worth understanding. Some adults over 60 who experience these brief visual disturbances also have a history of migraine, even migraines they had decades ago and have not considered since. There is a specific vascular profile that connects a history of migraine with aura to elevated stroke risk in older adults, particularly in women. If that resembles your history, bring it up to your doctor by name, not because migraine triggers stroke, but because they share vascular mechanisms that amplify risk when other factors are present. It alters what your doctor investigates. Now, warning sign number 4 involves blood pressure, but not in the direction most people anticipate. The way this actually operates is almost the exact opposite of what most people have been informed, and getting it backwards is precisely how strokes occur at night while people are sleeping peacefully. Warning sign number 4, sudden numbness or tingling on one side of your body, not the familiar pins and needles from sleeping on your arm wrong. This is different in 3 specific ways. It arrives while you are fully awake and moving normally. It involves one side of your body, one arm, one hand, one side of the face, and it fades on its own within a few minutes without you doing anything to make it stop. The reason it is one-sided matters. Each hemisphere of your brain controls and perceives the opposite side of your body. When blood flow drops to a specific zone of your brain, even briefly, the part of your body mapped to that zone goes offline. You experience it as numbness or tingling, then flow returns and sensation recovers. When both hands go numb evenly at the same time, that typically indicates somewhere else. Spine, neck compression, circulation in the hands. But sudden one-sided numbness that resolves in a few minutes with no obvious trigger is a vascular event until a physician proves otherwise. Here is the blood pressure detail that almost nobody communicates. And this is the part that catches people completely unprepared. Everyone understands that chronically high blood pressure damages vessel walls over years. That piece is well established. What almost nobody communicates is this. An ischemic stroke, the kind caused by a clot blocking a narrowed artery, often does not occur at the peak of blood pressure. It often occurs at a relative low point. Picture a brain artery that is already narrowed by more than half because of plaque accumulation. It is like a garden hose someone has pinched in the middle. As long as the pressure in the system is high enough, some water still pushes through that tight point. But if overall pressure drops, even to what most people would consider a normal reading, the flow through that narrowed segment can fall to nearly nothing, especially if a small clot is lodged there and there is not enough force in the system to push it along. At night, while you sleep, blood pressure naturally decreases by roughly 15 to 20%. This is normal physiology, not a disease. But if you already have a narrowed artery, that nighttime dip can convert a partial blockage into a full stop. That is one reason some people go to bed feeling fine and wake up unable to move one side of their body. The numbness episode during the day, the one they rationalized away, was their artery signaling them it was running out of margin. Now, warning sign number 3 involves the cerebellum, the balance center at the back of your brain. And most people assume stroke-related dizziness feels dramatic, the whole room spinning violently. But the version that actually precedes a stroke is often far subtler than that. And there is one specific sleeping habit that can be silently compressing the exact arteries that supply this part of your brain. Something almost no physician brings up unless you inquire directly. Warning sign number 3, sudden loss of coordination. What some people describe as a drunk walk without any alcohol. You are on a floor you have crossed 1,000 times, flat, familiar, nothing in the way, and out of nowhere your foot lands wrong, your leg feels rubbery, or you grab the door frame because the room seemed to shift, or a sudden powerful spinning sensation strikes with no obvious cause. You did not just roll over in bed, you did not jerk your head, you were just standing there. The cerebellum sits low at the back of your skull and performs a constant calculation. Where is the body in space? How hard does each muscle fire? What does the next step need to look like? It receives its blood supply from arteries that travel up through the bones in the back of your neck, what physicians call the vertebrobasilar system. If flow in those arteries drops suddenly, even for seconds, the cerebellum glitches. You stagger, you grab something, and then it passes. Here is why this one gets overlooked more consistently than any other warning sign in adults over 60. Balance naturally becomes less precise with age. The inner ear loses some sensitivity, so when a brief cerebellar event occurs, when the brain genuinely loses blood flow for a few seconds, it gets categorized as just getting older. The symptom is real. The cause attributed to it is wrong. Now, here is the sleeping habit detail that almost never surfaces in a standard appointment. The vertebrobasilar arteries, the ones feeding the back of your brain, travel through the vertebrae in your neck. Certain sustained neck positions, particularly stomach sleeping with the head rotated hard to one side, can compress these arteries enough to diminish flow, especially in people who already have some degree of arterial narrowing from plaque. This does not mean neck position alone triggers stroke, but if you have been having coordination episodes and you are a stomach sleeper, that detail belongs in the discussion with your doctor. Most patients never think to share it. Most doctors never think to ask. Benign dizziness from an inner ear condition usually has a predictable trigger: rolling over, quick head turns, a known diagnosis. Spontaneous intense dizziness paired with any trouble walking straight is a vascular sign until proven otherwise. Now, warning sign number 2 involves speech, and there is a version of speech disruption that is so subtle, so easy to explain away as tiredness or age that it gets dismissed for months before the stroke actually occurs. This particular version almost never appears on the standard warning sign list, but in working with this age group, it shows up in patient histories more than almost anything else. Warning sign number 2, sudden serious speech breakdown. Let me be specific about what this is not. Forgetting your neighbor's name is not a stroke warning. Losing a word when you are tired, that is normal. That is not what I am describing. What I am describing is when speech collapses badly enough that even you sense something is seriously wrong. There are 2 ways this presents. The first, you know exactly what you want to say. You can hear it clearly in your mind, but the words will not come out right. They come out slurred, stuck, or fragmented. The second, you speak fluently, but what comes out makes no sense, word salad, and you may not be able to follow what someone says back to you. Both involve specific speech areas of the brain, regions that when they lose blood flow, even briefly stop functioning, and both can self-correct within minutes, leaving you thinking it was a fluke. It was not a fluke. Here is the subtle version that almost never gets addressed. Some people, in the hours before a stroke, notice that thinking feels slightly fragmented, not confused exactly, but like finding the next word takes just a fraction longer than it should. Sentences begin and then stall. The thought finishes, but there was a moment in the middle where the connection felt loose. Adults over 60 almost always attribute this to tiredness, to age, to not enough coffee. In most cases, they are correct, but when that sensation is new, when it is occurring more frequently over the course of a day or two, and when it is appearing alongside any other item on this list, it belongs in the same discussion with your doctor. The speech areas of the brain are among the most metabolically active regions in the entire cortex, and among the first to signal reduced blood flow. A brief speech breakdown that resolves on its own is one of the strongest clinical indicators of a TIA. Treating it like a fluke is like your smoke alarm going off, going silent, and you deciding it was probably a sensor malfunction. You do not go back to sleep. You find out what triggered it. I want to pause here and ask you something directly. Why? Because someone watching this right now needs to hear it. Have you ever had a moment where part of your face or one arm felt unusual for a few minutes and went back to normal? Or a moment where speech felt slightly off for just a minute and then resolved? If the answer is yes, type it in the comments below. Not because the engagement is needed, but because someone else watching this right now is sitting with that exact same experience and has not yet voiced it to anyone. Your description might be the thing that gets them to make the appointment. Now, warning sign number 1 is the one that surprises almost everyone. It is not on the list distributed at health fairs. Most doctors do not link it to stroke risk during a routine visit, but the mechanism behind it connects directly to something happening inside your arteries right now, And there is a group of people over 60 who have been carrying this risk for years without a single doctor ever connecting the dots for them. Warning sign number 1, a specific skin condition combined with new, unusually intense headaches. The skin condition is vitiligo, patches of skin where pigment-producing cells have stopped functioning, leaving pale or white patches. Vitiligo is an autoimmune process. The immune system attacks its own cells, in this case, the pigment cells in the skin. Here is the connection most people are never informed about. When the immune system goes off target like that, it frequently does not restrict itself to one tissue. That same autoimmune activity can quietly inflame the inner lining of blood vessels, a microscopically thin layer of cells called the endothelium. When the endothelium is healthy, blood passes through smoothly and nothing adheres to the walls. When it gets chronically inflamed, the surface becomes rough and scarred. Cholesterol and platelets start attaching to those rough patches. Over years, those deposits become plaques. The artery narrows, and one day a small clot forms on that plaque and seals the opening entirely. That is how an ischemic stroke occurs. And autoimmune inflammation is one of the lesser discussed accelerators of that entire process. Now, here is the detail that the people who need to hear this most have almost certainly never been informed about. Vitiligo is not the only autoimmune condition that carries this vascular risk. Rheumatoid arthritis, psoriasis, lupus, Hashimoto's thyroiditis, all of these involve chronic systemic immune activation. And that activation does not remain neatly inside the joint or the thyroid or the skin. The same inflammatory proteins circulate in the bloodstream and interact with vessel walls over years. Adults over 60 who have lived with any of these conditions for a decade or more have often been accumulating vascular damage at a rate that their cholesterol panel and blood pressure readings do not fully reflect. The standard numbers appear acceptable. The vessel walls tell a different story. If you have an autoimmune condition of any kind, and you have never had a specific conversation with your doctor about stroke risk and vascular age, not general cardiovascular health, but specifically stroke risk, that conversation is overdue. Vitiligo alone does not forecast a stroke, but when someone with any autoimmune condition develops headaches that are new, different in character, stronger than their usual pattern, appearing more frequently, that combination deserves a vascular evaluation, not just a prescription for ibuprofen. And one more thing about headaches that is worth comprehending clearly. A very common source of chronic head pain in adults over 60 is degeneration in the small joints between the second and third vertebrae in the neck, essentially arthritis that irritates nerves and sends pain upward into the skull. This has nothing to do with stroke, which is exactly why headaches need to be investigated, not just suppressed. When a headache is new in character and when it is appearing alongside any of the other warning signs covered in this video, that is not a coincidence to manage with pain medication. That is a pattern to present to a doctor. Now, the 72-hour window and the 3 specific evaluations worth requesting by name. The 72 hours is not a vague phrase. It is based on what research demonstrates about when stroke risk peaks after a transient ischemic attack. But here is what most people do not learn. The window does not mean you have 72 hours before you have to take action. It means you have 72 hours during which intervention can dramatically alter the outcome. The gap between acting in that window and waiting to see how you feel next week is the difference between catching a near-total arterial blockage before it fully closes and waking up unable to move your right hand. The first evaluation worth requesting by name is a carotid duplex ultrasound, not a standard ultrasound. This one reveals both the structure of the carotid artery in your neck and how blood is actually flowing through it, including whether flow is becoming turbulent at a narrowed section. If the artery is narrowed by more than roughly 70%, the question stops being whether a stroke might occur and becomes when it will occur if nothing changes. At that threshold, surgeons often recommend removing the plaque directly, a procedure that in modern practice is routine and prevents tens of thousands of strokes every year. The second is glycated hemoglobin, HbA1c. This measures your average blood sugar over the past 3 months. You cannot manipulate the result with one clean fasting day before the draw. It catches the gray zone called pre-diabetes, where blood sugar has been high enough long enough to damage the endothelium and accelerate plaque formation, but nobody has assigned it a formal label yet. Under 5.7% is normal. Between 5.7 and 6.4 is prediabetes. At 6.5 and above, that meets diabetes. Here is something that rarely gets stated plainly. The damage that chronically elevated blood sugar does to vessel walls begins years before anyone labels it prediabetes. A result of 5.4 or 5.5% technically normal in someone who has also been carrying extra weight around the midsection for a decade, who consumes a diet high in refined carbohydrates, who has a strong family history of type 2 diabetes. That person's vessels may be in significantly worse condition than the number alone indicates. The number starts the conversation. It does not conclude it. The third is a Holter monitor, a 24-hour heart rhythm recording worn during your normal day. A standard EKG in a clinic lasts maybe 15 seconds. Some dangerous rhythm problems come and go and get missed entirely by that short snapshot. The most significant rhythm problem for stroke is atrial fibrillation, where the upper chambers of the heart stop beating in an organized pattern and instead quiver rapidly, causing blood to pool and clot. Those clots travel to the brain. This kind of stroke tends to be severe. Many people with atrial fibrillation sense almost nothing, an occasional flutter, a skipped beat they attribute to caffeine. Holter monitoring is what detects these hidden episodes, and if atrial fibrillation is discovered, medications that are well studied and properly managed can reduce stroke risk in this condition by roughly 60 to 70%. That is not destiny. That is a risk you and your cardiologist can actively address. One detail worth understanding: if a 24-hour Holter comes back clean, but symptoms or risk factors still justify concern, a longer recording period of 48 hours or even a week is a reasonable next step to inquire about. The technology exists. It just does not always get recommended unless you know to request. Think about the person sitting closest to you in your daily life right now. Your spouse at the other end of the couch, your brother you speak to every Sunday morning, your daughter who has been getting headaches. She cannot explain. The 5 warning signs in this video apply to them as much as they apply to you. Sometimes understanding something like this is more valuable to share with someone else than to keep for yourself. Here is what to do within the next hour. Write down any episode from your own experience that matches what was covered, even if it was months ago, even if it seemed minor. A moment of visual disturbance in one eye, numbness on one side that arrived and departed, an episode of dizziness with no clear cause, a moment where speech felt wrong. Write it down in plain language: what occurred, how long it lasted, what you assumed it was. Bring that written list to your next appointment and pose 2 direct questions. Should I be evaluated for transient ischemic attacks, and do any of the 3 tests discussed here make sense for my situation? That written list is the 30-day commitment, not a diet overhaul, not a supplement routine, just the commitment to stop letting these episodes pass without a record. By the end of 30 days of paying attention and keeping that log, you will have something concrete and specific to present to your doctor, the kind of information that changes what gets ordered and what gets detected. In stroke medicine, that is not a small thing. It is everything. If this video provided you something real, subscribe now, because the next video addresses something this audience needs to learn. What your resting heart rate is actually communicating after 60, and why the number your doctor labels fine may not be revealing the whole story. Missing that one matters.